Hello, welcome back to my channel. How you all doing? So today I'm going to be having a guest on this video. Her name is Shulamite Antenatal. She's a registered midwife in Nigeria and now in the UK, presently practicing. And she's going to be sharing with you her thoughts, her journey, and everything that you need to know about becoming a midwife in the UK. So I do encourage you to stick right to the end.
My name is Shulamite Antenatal. Many people call me Shawmi, so you can call me Shawmi. And I am a mother. I'm a mother, a wife, and a midwife.
A proud one at that.
I am trained in Nigeria and got registered with Nursing and Midwifery Council of Nigeria as a registered licensed midwife, and that happened in 2010 when I graduated. I had a 3 years basic midwifery course and came out with a diploma. So,
yeah,
10 years after, I'm in the UK.
Welcome now. I know it's not easy moving house in the UK. It's not easy. Did you get the accommodation yourself, or did the hospital?
I got it myself. The hospital has given me 2 months, which has expired. Yeah.
A lot of people I know, both nurses, midwives, and students alike, they're always mentioning to produce guarantor. Were you asked to bring
First, I got an agent. I was requesting for a guarantor that is earning close to £40,000, but that was so much, and I couldn't get someone like that. So I now got another landlord that requested just for employer.
Okay.
I spoke with the landlord directly, so he requested for just employer reference, just landlord reference.
Or where did you find the landlord?
Well, it was a referral because I was using website Zoopla, and Rightmove, but this particular one was a referral that I got, from a friend.
Okay. So I'm glad that is sorted out for you anyway. What are your plans to furnishing your house?
I had friends who have been helping me with moving, furnishing the house, decorating the house, and also I have to get some few things because it's not a furnished apartment.
Right, so help is a lot of things. I'm asking these things because it may look like a very simple thing, but a lot of people will find it when they first move to an apartment, because most people will go into employee apartment and they will just be comfortable, and then that first step out of the comfort zone becomes a big challenge for them. So help is a big thing. Okay, so let's focus on midwifery now. How has it been so far?
Wonderful.
Okay, so I think that says a lot. Now, comparing community practice, what aspects do you think are really relate them to UK practice? What are the things that you think are very, very with practice here, if you want to compare it with midwifery back home?
Okay, the things that are outstanding here is that their care is patient-centered, and you have to give a quality care. You don't pressure a patient to do what they don't want to do. Don't give them your own choice of view. This is how the doctor wants it to be done. This is what the surgeon says, that's different. You always want to know, is it okay for the patient? And you also think at the back of your mind, the choice you're trying to present or what you want to push to the patient to do is going to be safe. And it's always about a scientific rationale, trying to find out what is the guidelines, protocols, and the NMC code, you know, just trying to be strictly formal. Yeah.
Okay. Now I like that point because back home we have this culture of always telling the patients what to do. Like now, I'm believing that I've had a couple of deliveries done it by yourself. You've watched whatever they are doing. You've seen how they prioritize things. We describe the midwife as autonomous in their practice or dependent on the doctors. How free are they to practice? Dependent are they in their practice?
The truth is that the program I did is a basic midwifery program, which is 3 years, and it is a program that trains you to be autonomous. So in Nigeria, you can open a health agency yourself without a doctor. You can be sent to work in a health center where you take your decisions, you make your prescriptions, then you choose the low risk pregnancies to manage. The ones you detect as going to be high risk, you refer. You have to follow the rules, the guidelines, you know. So I think I was like that, and I started in the community where I take such decisions. So to the UK, it's nothing different compared to when
Okay.
you get a train and go straight to the hospital somehow in Nigeria and you do what the doctors ask you to do. So here in the UK, is
Thank you
more
very
of an
much.
autonomous. So you also work in some departments that are high risk maternity departments. There you have to take decisions based on protocols, and also you have to get the doctors involved because it's a high risk pregnancy that you're dealing with. But the wife-led clinic that you're dealing with, or in the communities, of course, you have to be careful. You have to know your onions. You have to know that the decisions are yours to make, and then know the consequences of making a wrong decision. And if you're not sure, you ask questions or you refer.
All right, that's very, very, very beautiful to know. Now, I want to ask in relation to, like, just like you mentioned in your just now, that if you are in Nigeria and you practiced in the hospital setting, now you're because you have this autonomy of practicing in the community, making decisions. So it's just like to your role in the UK. But for a midwife who probably has practiced the hospital in Nigeria, and they're trying to transition to becoming midwives in the UK, what is the one advice you would give to them when they get to the UK?
Fine. The first advice I will give is read, read, read. I think why the practice in Nigeria is the way it is because people don't like reading. And there is this
Okay.
proverb that says, if you want to hide something from an African, put it in writing because
This
they
is
don't
their
want to
book.
read it.
Yeah.
Yeah, this is the
Mm-hmm.
Western, or they read a lot. They want to know more.
Yeah.
They go ahead and research. So you have to read, get to know what the system is because it's different. And when you come here, you don't just call a doctor and was like, please, I need your help. A woman is this, a woman is that. You will be like, okay, what do you want me to do? And if
What's
you
the
come with the
problem?
African mentality, you'll be like, my God, you're a doctor. I just called you. He's there asking, okay, what do you want me to do? He wants to be sure that you know why you are calling him and that he understands his role
Exactly.
in you calling him. You don't just call like back home, you just go, hello, doctor, please I need your help. The woman is in labor. He just comes in and okay, what's going on? And he starts doing things. But here, you don't do that. Yeah, doc, please I need your help. Okay, what do you want me to
Yeah.
do? So you just have to know what you're doing and know when to call the doctors, and they come and do their job. You have your own job.
It gives me a lot of joy because it's just when you like, for instance, say the midwives or the doctor or nurses just call doctors. I'm like, hey, and you're just screaming. The first question you always be asked here is, what is to do? Now we are all doctor is the all and all. Like, I don't know earning rate is over there. But here you are seeing the difference in economy, the difference in your knowledge, how you are allowed to put your knowledge to practice. As a matter of fact, you are able to confront the doctors if they are doing something wrong and you're the head. If you do not speak up, you know you're, so that's one very big thing. So in antenatal care, I know we probably were taught focused antenatal care, which nobody is actually practicing back home. The way antenatal care is given here is focused.
Yes.
Is it just every to the clinic, take your blood pressure, blah blah, and go back? Do you think it's focused? And do you think is different or interesting about the way the antenatal is run here?
The answer to that question is yes. Like I said, the training of basic midwifery is actually like the same one, right? That 3 years training, we use Margaret Miles, all over the world recognized. So it is the same practice. We are taught antenatal. You're meant to involve the partner, be with the mother, talk to her. Patient is different. Every pregnancy is different. It doesn't matter what you feel, or maybe I'm trying to compare my own pregnancy with your own pregnancy. No, it's not the same. Her first pregnancy might not come with signs and symptoms with the second pregnancy. And the way we do it in Nigeria, we gather people and we give the health talks, and that's why they find it as a job. They dance, these women, they see one another, they share experiences, but it doesn't give you that one-on-one opportunity for a woman to disclose certain things to you. No one wants to talk about her issues in public. So this is exactly different, as in like it's different in UK. You have someone coming to you and you're speaking to the person, you are trying to draw the person out, and she can open up and tell you things that she might not say when you are in the public. And you give a focus care. Is she having a medical condition? What is different? What is going to make her pregnancy eventful or uneventful? You just give her that special care that is different from what you give to another person, not a generalized care.
Thank you very much. Now, going to my next question, because event pregnancies you mentioned here, they have what they call planned births. Okay, having hospital beds, home beds, and we all know the pros and cons of these hospital beds and home beds. In Nigeria, people have home beds, but they're usually unsafe and well guarded, which leads to a lot of deaths and complications that come from it. Now, what do you think? And probably most midwives from Nigeria will be like, have a baby at home in the first place. I'm sure you know that is something that is even advised here, or people, or even the chance to make your decision. So what do you think can be done? Okay, I don't know if it's something that was taught in basic midwifery, but what do you think can be done to inculcate this home beds, make it something that becomes normal for Africans? That most African mothers have the capacity to actually have home beds and have it safely, but there's just this gap of probably lack of information, or probably lack of the midwives themselves accepting it as a normal thing. So what do you think can be done to make home something safe and accepted in Nigeria and Africa?
Okay, it is taught in the program, in basic midwifery program. It is a practice that we graduate in basic midwifery program. You can conduct home births. That is why you are called a community midwife.
Okay.
And after my training, I had a 1-year compulsory placement called under the midwife service scheme then. And the federal government had a wonderful arrangement then, whereby they train some people in the communities which these women know, so that they can accept us. The problem we actually have, because we are a developing country, we are really trying our best
Yeah.
to see that we reduce maternal
Okay.
mortality and infant mortality. So the program then was set up in a way that midwives can actually conduct home births, or let
Okay.
these women come to the health center. But what is the aim? So that the births will be attended by a trained professional, because they patronize professional birth attendants where
Okay.
they practice a lot of things that are not safe. So we have to bring the care to them. It's community based. Then we do home visiting, we do community mobilization. You know, they get to know us, you visit them at home, you follow them up 6 weeks, you come and teach them how to breastfeed, you talk about malaria, mosquitoes, you show them how to garden around themselves, how to clear bushes, how to empty stagnant waters, you know, get them involved, come to their markets, be with them. Like, yes, Nigeria has it. We practice it. But your question, based on what can we do more, is I think we lack will I say that we lack adequate health care, or we lack people that just people don't want to be in the community. That I think that's the answer to the question. Everyone wants to graduate and run to the
Yeah.
urban areas. No one wants
Okay.
to be in the health centers
Okay.
because the health centers don't have enough equipment. You know, when you are
Equipment.
there to work, you find yourself struggling. So, and federal government is actually doing their best to bring these structures up and put in trained professionals, but I don't think it has gotten to the standard that we have in the UK here, where you can actually confidently and comfortably have home births and then practice community midwifery
Basically,
safely.
I mean, wives rather don't want to practice in the community. But here in the UK, it's like that's where it starts from. It's the basic thing. You can't even go to childbirth without having spoken to your community midwife, the GP surgeries, and then move upward to decide where you want to have. Now being in the UK as a midwife, what are the effects that you see? How do you see yourself? Because I one thing I always advise overseas nurses is, or midwives is, whenever you get here, don't get complacent about your practice, or don't get too like you've arrived and that's it. So what do you think going forward career wise that you have seen? What are the opportunities that you have seen? What do you think can be done? What do you think can be achieved? You know, how do you see yourself 5 years, 6 years from as a midwife in the UK?
You know why I'm just smiling? Like, this is the best part of midwifery for me in the UK. Nigeria,
Yeah.
once you're done as a midwife, I don't know why the system is like that, but I'm sorry to say that it's not fair. Once you're done with your 3 years basic
Yeah.
training in midwifery, that's it. If you want to progress, you either go
Yeah.
back and do an 18 months nursing program before you can actually get a BSc direct entry. If not, you go back and write JAM and start as a first year student to do
And
your
go to
BSc in
BSc.
nursing. It doesn't
Yeah.
make sense. You want to be a midwife, you be a
Yeah,
midwife. You
at
want
all.
to be a nurse, you be a nurse. Now in the UK, it is so
It's a
exciting. In
choice.
fact, that was what attracted me to the UK in the first place. It is so exciting to have that a midwifery pathway in the UK. You can
Yeah.
progress to your master's level in midwifery. You can
Yeah.
progress to the PhD level in midwifery. Isn't that wonderful? You have a program, you
Yes.
have a career, and you just follow it. So you don't just jump from midwifery to nursing, and the
Yeah, into
nursing will now
something
say,
else.
oh, you need to have a specialty in nursing, and you jump out again to get into orthopedic nursing, and you jump out again to do psychiatric nursing. It doesn't make sense. Like, you want to be a midwife, you just have to progress,
Yeah.
you know, like
Being a midwife.
develop yourself so that what you are today will not be what you will be like in the next 3 years, in the next 4 years. The difference is clear. So that's it.
Yeah. Good. I'm really excited about that because a lot of, in fact, I think the midwives even have it easy yeah. Unlike in where you have to applying for a B6 or trying to look for a specialty where you grow into from. As a midwife, that's already a specialty. So it's like improving yourself, looking out for opportunities, and looking at things. I mean, everybody can get tired of delivering babies, or you can actually get other interests in teaching, other interests in lecturing other midwives, and your career just grows from there. So I'm glad that you are in that route.